Hey guys, I am back in my room finally. We just finished the Facial Pain Association conference. Friday was the volunteer night, and then Saturday and Sunday were the conference presentations, and I just want to say it was so amazing. Got to hear from a lot of doctors, surgeons, dentists from all over the country and even outside of the country. I just want to thank those people so much for changing so many of our lives and putting all the effort into it that you guys do. It really is important because so few doctors focus on these rare facial pain conditions. I got to meet a lot of new friends and friends that I've had online for a while, so that was also amazing. And just the FPA for putting on this event. It was so awesome. I can't wait to attend in the years to come, and I think a lot of people feel the same way, so thank you. I wanted to share some video content and photos that I took throughout the conference.
Thinking about optimizing it, you're on usually medications for neuropathic pain. Even if you're in remission, you had an NPD or a procedure of some other type, and you're pain-free, drug-free, you've been on meds, you know that work. You can either go back on them or you can increase them. And so you have to know the half-life of the drug and when to kind of increase it. They're all specific, they're all different. But you want it going up before. You want to keep it during the procedure. Usually the procedure is minutes, so that's not a hard one. You want to keep it after. And that after part is, how big is that procedure? How much tissue is involved? What inflammation is there? How long is it going to be sensitive? If it's a simple root canal of lower front tooth, it could be 3 to 5 days. If it's a third molar impacted tooth that takes a surgical extraction with bone removal, that's 10 days plus, okay? And so you have to plan related to what that is. You can also do add-ons. Sometimes you've tried some other medications that have worked, they just give you way too many side effects. Well, now's the time to maybe say, I'm gonna decrease my activities, take some time off, and use the medications. A mantra, in some ways, more than a mantra, about how to manage your own anxiety. It's catastrophizing, pain-related catastrophizing, because we know it's so much related to the continuation, chronification of pain. Good local anesthetic. What I absolutely don't want is a dentist doing a local anesthetic and then let's get going. Like, no. This is the absolute last person that you want to be rushing this. It usually takes a good 10 minutes for local anesthetic to kick in. Remember, they're on this assembly line. And so if their timing's not right, you need to say, stop. I'm not fully numb yet. They might not like you that much, but they know you're right. Obviously, there's no spinal or central blocks in dentistry, but do a regional block and an infiltration. Double your chances. The obvious is I like people to take NSAIDs. Most people will say, well, I've tried NSAIDs for my pain, it doesn't work. We're not treating your neuropathic pain. We're treating the post-surgical, inflammatory, peripheral pain. We know NSAIDs work for that. Why not use it? In many different ways. Here's an example. 800 milligrams of ibuprofen. I want it 3 times a day, the day before minimum. You want to get that anti-inflammatory up. Analgesic effect kicks in about 20 minutes to its full effect in an hour. The anti-inflammatory effect needs to be pretty close to max dose and 4 half-lives ahead of time. So you need to start the day before if you're going to want to suppress inflammation. Not great in inflammation, but why not? The one to use is the one that you like. If you like ibuprofen, use ibuprofen. If you think
if they meet those criteria, similar pain, similar distribution, hasn't turned to a neuropathic patients, though, it's two things. First of all, the complication profile for an MBD is very well known. It's a very safe surgery. I think the most common complication is probably a CSF leak. Okay. I typically tell patients risk is probably doubled, just hypothetically. I think it's a double rate of leak, infection, neurological injury. They're already super low, but I'd say hypothetically, because we're dealing with scar tissue, it's a riskier surgery. It'll take a little bit longer. But more importantly, we don't have good data on efficacy, long-term efficacy for revision of BDs. Again, personally, the ones I've done now, all except one are pain-free. And so typically we talk about if someone has classic trigeminal neuralgia, 10-year pain-free rates are like 80–90%. The problem is I can't give that same data for a revision one. I can't say it's going to be the same 10 years from now. Clearly you failed within 1 year. So that's something we still have to explore. There's very little papers on that actually.
I have a question to that. So you would revise. Would that be the same thing if you did the primary?
Hasn't come to that yet, but yeah, I would. And so
then what are you looking for? What did you miss the first time?
So every instance where I've revised it, all 11 so far in the past year, has been incompletely decompressed. So I'll still find neurovascular compression.
Definitely go to a headache specialist neurologist for sure, because facial pain is a headache disorder. That's how it's classified. Sometimes it doesn't feel like it, and they don't understand what you're talking about, but it is a headache disorder, and they will definitely know more than a general neurologist.
I guess the nuance of that question is if you have to wait 10 months for a headache specialist versus 1 month for a general neurologist, who should you go to?
I did have to wait, and I was on the waiting list for them, so I did see the neurologist in time to get some
Yeah.
treatment.
That's even better. Go to both.
Jefferson Head Clinic, really.
So I think that's an important point to raise. Trigeminal neuralgia, facial pain in general, neurologists all training it in general, neurosurgeons all know the techniques that need to be applied. There is specialized knowledge that helps. I think for people who don't have access to a neurologist, a general neurologist is really fine, as long as, again, you have that conversation about what's your familiarity with facial pain. But sometimes waiting, if you have to wait for a long time, which typically for headache neurologists you do, bridging the gap is critical.
I've been talking about how impactful, to answer your question, this is, because it gives us a little bit of time to try to organize and strategize and think about what we want to do for the future. Even though we're all working on all different aspects, but there's a voice and a synergy that emerges. So for us personally, from my perspective, I can't speak for anybody else. It's very impactful to have that time together.
I want to thank all of you for sharing yourselves, your stories, your time, and everything that you've given to all of us. I know that the doctors are impacted. I know that myself and Regina and Natalie, as a staff, we are all impacted. This gives us the steps forward. This gives us the places to go and tells us how we need to proceed to continue to serve this community, and it's so important. So I really, really appreciate all the time and the emotion and everything that you've put into this. It means everything to all of us. Our board of directors is here. I really want to thank our medical advisory board. I did this morning, but only a few people were in there. They're an incredible group, and our board of directors. These 24 people dedicate so much of their time to helping us steer this organization in a direction that is appropriate and impactful and of service to you, and particularly our MAB who spoke here today. And then as we've planned this conference over the past year, I've really gotten to know this team at University of Minnesota, and I specifically want to thank Dr. Nixdorf and Dr. Grand and Dr. Darrow, who played an enormous part in putting this program together. They invited doctors from their team. All of these people that were presenting, a lot of these people that were presenting today were from this center, and I think it's an excellent model for a multidisciplinary center where people are working together, they're collaborating collaborating to try and figure out really complex and complicated problems. And it's so important when, as you know, you're trying to figure out what your next steps are. So I thank them for not only bringing their team in, but then inviting people also from all over the country to speak, and then adding our medical advisory board to that group.